Managing complications, CSF leaks. So we're going to stay in the same arena as Stacy, but switching gears slightly. So basically, if you think about classification of CSF leaks, this is what I think about it, is essentially 4 big categories we're thinking about. Head trauma or surgical trauma, spontaneous, so this is your IIH, pituitary leaks, which are essentially skull-based but very small leaks, and then your very large skull-based defects. Just for the purposes of our talk, we are gonna just whittle it down to surgical trauma. So essentially, intraoperative sinus surgery trauma. Nothing like this, but I joke and I say I learned a lot of my principles for closures based on a lot of our big skull-based reconstructions. That's where our principles have come from. First, curious, quick show of hands. How many people have ever had an intraoperative CSF leak on a FAST case? Any takers? All right, got a handful. Okay, so just curious, but let's kind of go through this. So if you think about surgical trauma, we're going to think about what we're looking at in the CT scans beforehand that potentially can give us problems, right? So avoidance is always a key point. So take a look at that CT scan. If it's revision surgery, what bone has been resected? The board's question always comes up that the right side is more common, and the concept of that, if you haven't heard this, is most surgeons are right-handed, and so if you're going on the right side, you're pivoting slightly medial, so towards the cribriform. So the right side, you want to think about that your body's shifting yourself medial a little bit more. The lateral lamella of that cribriform is going to be that softer bone, so the more medial you go, the softer that bone is. And then this is I'm not going to say controversial, but something we talk about. But FES injuries typically happen in an infected field, so in theory, it's a little different field than some other trauma. And generally, prompt repair is successful. So easiest solution, avoidance. We know this. So it's a look at that preoperative CT scan, spend some time with that, and then understand where you are intraoperatively related to the skull base. And this is what's, to me, is really, really important, is where are you at all times? And I don't mean by every little cell, but where are you relative to that skull base? So a few basic points when we think about the skull base is look at that asymmetry. So if you have some asymmetry on the area itself from right to left, just pay attention to that when you're coming in there. And then you want to pay extra care on that right-hand side, especially if you're doing any turbinate reduction. And then that height of the ethmoid is really what's key. So if you look at this scan, this maxillary is really large. So when you have that large maxillary, what that means is there's just a fixed amount of space between the floor and the skull base. So if you have a large maxillary, you're going to have a small ethmoid. Okay, so think about that. Large maxillaries, immediately that should put up radar, like that radar should go off, that you don't have as much room in that skull base. And again, the obvious one, do not blindly trust your image guidance. There have been many a surgeon that has been fooled by that. So the 2 most common areas that I see leaks that get transferred in are posterior ethmoids or finding the frontal sinus. So the posterior ethmoid tends to be often with that 0-degree scope, and really what it is when you pass through that ground lamella. So the issue is when you pass through that ground lamella, essentially that area is a bit of a fulcrum for yourself. So what you're going to do is when you look at if you're passing through that ground lamella in this area, you've got all that space here. Now, flip side, and I'm sorry, you're going to see the same thing on your sagittal. So if you go through the ground lamella at this height, this is how much room you have. Now, conversely, if you go through it higher up, you have less room. So if you enter that ground lamella a little bit higher up, it's not necessarily dangerous entering it there. It's that your body's getting fooled or your eyes are getting fooled to telling you that there's more room than there is for the skull base. So you really got to think about that, and that's why I really counsel and saying enter as low as you can on that ground lamella. And then the same token, this is looking at that sagittal, but here is if you enter low versus if you enter high, you just see that little difference in height. And again, it doesn't look like a lot, but that's the difference when you're looking at how much more room you have on that skull base. And again, it's showing the exact same thing there. So looking at a video this is a patient's left-hand side. Patient's left-hand side. And here is your turbinate here. maxillary, you're going to see a little bit here, but I really want to enter at that height of that roof of that maxillary sinus. So they traditionally teach that height because if you go too low, you're destabilizing that middle turbinate. If you go too high, you're worried about that skull base. I tend to err low, and then I typically suture my middle turbinates back together just to restabilize them. So I always err on the lower side of this. But my goal is exactly what we talked about, is I want to enter really low on that sinus and not enter up high where potentially I can get in trouble. So let's say we get the intraop CSF leak. So we're there, we did what we just talked about, but we may have gotten a leak. The question is, do you have to do anything, right? So we've been taught trauma in general, most trauma, car accidents, crashes, et cetera, patients will close up spontaneously. So we know that in trauma cases, now the difference in FES, and it has not been formally studied for kind of obvious reasons, is there's a concept that you're in an infected field. So are you introducing, with these dirty instruments, are you introducing infection into that area? Now, truthfully, we don't really know this. It has come up in the medical legal spheres that this is a reason that you do want to repair these right up front, because people have hypothesized that they have a higher rate of infection in these patients, but just something to think about. So let's say you're here. We're now in the posterior ethmoids. We see this. This is oh man, I'm really stressed out what's happening here. So first things first, stop and reassess where you are, okay? Just stop. It's not the end of the world getting a CSF leak. Unlike some of those horrific pictures that Dr. Gray shows where you can't fix the optic nerve injury, a CSF leak, as long as you don't do any more damage, this is totally fixable. Patient can do fine. Second, confirm that where you're at and do not deny this. If you're a denier, I've seen those go really bad, and we'll show some examples of that. So think about where you are, and if you think this is what happened, that's fine. First thing I like to do is consider improving visualization. So pack off the cavity. Okay. Can you guys hear me? Cool. Okay. So next, pack the cavity, raise the head, take a few minutes. This is the time where you can scrub out, take a break, go look at the scans again, think about where you're at. I often say use the phone to friends, call somebody else, whether there's somebody in another OR next to you or whether there's somebody you can just call and just reevaluate things. And then establish whether, okay, this is a leak. Are you comfortable fixing this leak? So what does it mean when I say, are you comfortable fixing a leak? There's actually a number of factors here. Number one is, are you in a facility that you think you can repair this leak? Do you have the equipment to actually fix a leak? Are you prepared to handle the ramifications if your repair is unsuccessful? And then do you feel like you're in the right state of mind? Again, for the people who raised their hand and said they got a leak intraop, I mean, it is a nerve-wracking feeling where you're like, oh man, I'm in trouble here. So do you think you can regroup and feel like you can give a good repair? And then lastly, do you feel that you have the technical skills to repair the leak? That honest answer, and we'll go through this, that answer is likely yes. So number 5 is likely yes. It's the question is the other 4, do you have those there to ensure success? So going to the facilities, you really have to assess anesthesia. So everybody's been in areas where you have an anesthesiologist, so you're like, oh boy, this anesthesiologist, when we wake up this patient, we're gonna see the eyes popping out of the head. We're gonna see them bucking 10 times. Like that patient, you can do a beautiful reconstruction, but if they just blow that out right away, you're in trouble. Is there an anesthesiologist you can work with either for deep extubation, or I've seen some people where they'll switch the tube out for an LMA and essentially can kind of go slow with that, because otherwise, again, you're setting yourself up for something like a tension pneumocephalus, which is no good, and you're literally taking a stable situation and making it worse. And then secondly, admission facilities. It's my strong opinion that a patient after a CSF leak should be admitted afterwards. I have seen it done where patients have had a repair for these small leaks in a surgery center and sent home, and I think you can get away with that. The problem is, and I think everyone here has been there, where you tell a patient, okay, we had a problem, this happened, and they don't really register this. The family doesn't register this. They still go home. They go home with antibiotics. You said you got to be really, really careful. And then the next you know, and this patient actually, he was found out mowing his lawn like 4 days later after a case where they fixed it and sent him home. Now, you know, if you admit that patient, they finally realize, and you may not do anything different, they realize, okay, there has been a deviation from what was supposed to happen to what has happened. And it lets them process a little bit, not mad at you, but process that, hey, this doctor, he or she is doing what we need to do to repair this. Let me be careful on the back end for this. So you do want to be careful. And again, like I said, I feel strongly you should be admitted for that reason. So second, do we have the equipment to repair this? The equipment I like to use, I like an endoscopic bipolar. I'm going to show some videos of that. Not a suction cautery. A suction cautery can make things worse at the skull base where it can break that bone down worse. I, in general, like some sort of dural matrix. There's a million different companies that make the dural matrix. For these small CSF leaks that you get intraop from FEST, honestly, I don't think it really matters. You could use a small fat plug, no problem. And then I like tissue sealants. So large defects, I use Adherus, which is a Stryker product. Small defects, I don't think it matters at all. Tissue glue is what I typically use. And then in general, repairs can be done with routine sinus instruments. I think long needle tip Bovies help a lot given the extended reach, but in general, any sinus instrument can be used. Okay, so then the next question, are you prepared to handle the ramifications if your repair is unsuccessful? Here's two nice cases. Case number one was similar to that lawn mowing accident. This is a patient who was blowing his nose a week later and then essentially got transferred over us to our ICU because he had a lot of air in his head, tremendous headaches, where the leak repair was done, and I think it probably wasn't done poorly, and the patient just didn't cooperate with that, and you have to deal with this. Second patient had a leak repaired, and I think they were just leaking at such a small amount that you couldn't see it, and they created an epidural abscess that ultimately needed craniotomy and drainage, and then subsequent repair. So there are some downfield effects of this that, is this something you want to deal with or not? Again, the right answer only you can answer, but these are things to think about. And then the last thing, so are you in the right state of mind? So this is one of my favorite videos. So this is one of my partners that some of the team members here will know, but I love this video, and if it had audio, it's even better. So this is a patient that needed revision drill out. And I'm gonna show the video here in a second, but essentially tight frontal sinus up there, had a drill out before. Not sure if it was done same surgeon or outside, I don't remember, but essentially needed that drill out wide just because severe headaches in the frontal and it was just backed up. So for us, we typically use, for a lot of this osteotic bone, we typically use like the cutter drills. So the cutters tend to cut through quickly, but they also make a lot of damage real quickly. And immediately you can see a nice big dural rent there. So this guy is pouring out CSF there. And this is in real time, so he was like, get the gel foam out, plugged it with gel foam, all right, forget about it. And he just moves on to the next thing. So and this video is not changed too much, literally just opening up the sinus, not thinking twice about the leak. Because, again, at our institution and a lot of the academic institutions, we're used to fixing leaks for all sorts of reasons all the time, which is different than this conversation we're having here. And then what he does at the end, puts a little more gel foam in there, and then ultimately a free graft. Again, the closures on these CSF leaks are not complex. It's, do you have the equipment? Do you have the wherewithal? Do you have the anesthesia? And then do you feel good about them? But the actual closures are not hard. So that was a closure, very standard. And then this is, a month post-op. Patient's doing great. You'll see it. You see a little scab over that area. But again, patient does well. But again, the point I wanted to make there is that surgeon was very used to dealing with CSF leaks. Now, this is the opposite. This is a surgeon. He was a very good surgeon, does really good sinus work. He got an intraop leak. And what you're looking at here is after the leak, this is actually a piece of septal bone up here in the frontal lobe. So let me see if we can get that going. And we're going to see a coronal there in a second. So again, you see where that bone is right up there. So that's septal bone right up there. So this surgeon got a leak and patched it up. And so what he was doing when he got that leak was essentially do what we talked about. Okay, fine. Let's find the leak. Let's close it up. So took a piece of septal bone, and he actually put it up in that dead space. And unfortunately, I'll show you, and you're going to see this in a second, and this you can see where we're at here. And you see bone right there, or sorry, cartilage right there. And so as we look, you'll see it's leaking around, the CSF is leaking around the cartilage, and this patient had lost a lot of CSF. I took him in the next day. But essentially you'll see that CSF essentially leaking all around the area. And then this is a second layer of cartilage. So we're still, where we touch this is still not even close to where that bone is. So we had consulted with our neurosurgeons, and my neurosurgeon did suggest taking out, again, for the concept, this is likely infected bone that you've got way up there, so you're asking for a problem later on. So now I'm going up there, and then here's our bone defect, and we're taking down these pieces of cartilage. And you see me just kind of tracking up. And what had happened was when he put that first piece up, it had pushed up higher. So then he took another piece and he put it up there. Then he took another piece and essentially was like stacking poker chips and pushing it higher. And that was the last piece you saw going up to that frontal lobe itself. Fortunately, there was no vascular injury from this, so we got incredibly lucky. But that's where it was all pushed up. And here you can see your defect there, right? So surgeon, you just have to take my word for it. He's a very good surgeon. He was just put in a situation that you guys aren't in a lot of times. So his mental status wasn't there. So after that, and we'll talk about what we do, I typically will trim that middle terminus because I like visualization of the area. In this scenario, the defect was a little bit larger. And you can see that bony defect, and the dural defect is right there. So, and we'll go through all these steps here, but we essentially prep the area, raise a small nasoseptal flap, and put it on. And we'll talk about the utility of the nasoseptal flap versus a free graft. And then I did a tri-layer closure where I put a little bit of Duragent in there. And then given the size of the defect, I put a little bone graft in there as well, and then followed by that flap. But again, the point I want to make is if you look at the two cases, really the only difference in the two cases, I wouldn't say a skill set, it's just one person had the mentality that this is routine and no big deal, and the other person likely had not encountered one of these before, but had the technical skills to do it. Number of different ways to close these up, but this, I just put a bone graft here, and then, there's another piece of cartilage that had come out while I was doing it right there off the edge. And then a flap right over that. Perfect. And then, I used to use a little bit of glue just to get that water tight and then throw that flap right over that. And this patient did fine without issues. Sinuses were fine. So that's the key point. So when we go back to the final question is, do you have the technical skill? I think everyone in this room has a technical skill to repair it. It's those other four factors that are going to decide whether you want to do these and whether you're successful. So let's assume that you decide you are doing this. Do you need a nasoseptal flap? Absolutely not in the vast majority of cases. Free grafts work just fine for these type of closures. Larger closures is a different story. The data has been very clear. Vascularized flap helps. Small closures, these are totally fine to use free grafts. I tend to use a little more nasoseptal flaps. I do think they're more robust, and quite honestly, I think of it a little bit like double jeopardy. Like the patient's had one complication, and I really, really, really don't want to see it fail, so I go little belts and suspenders. But really, the other thing you want to do before you start this, establish, did we cause any other defect? Any other further injury. So this was a patient who sadly had a nice microdebrider into the brain. So think about, you got to be honest with yourself. If you think that where the hole was, you created other problems, do not go in there. At that point, that's a transfer over to an academic center. Let them deal with this. But you can, and this is the post-op. This patient actually did fine, but this was like, I don't know how many months post-op, but there's a big hole from that RAD 60 that went through there. So think about that. Now, when we think about reconstruction itself, this is an old picture from Bill Bolger, which is always, it was one of my, when I was a fellow, I saw this, one of my mentors, Jim Palmer, who trained under Bill Bolger, loved showing this picture, and I actually love it. If you think about CSF leak closures, there's three layers we gotta think about. There is the dura, there's the bone, and then there's the mucosa of the sinus. Always think of those three layers. They had to be transected through all three layers before you have a CSF leak. So if you think about those three layers, you then think about your reconstruction. Okay, how am I dealing with these three layers? And how you're dealing with these three layers is really depending on the size of the defect. So these two are very different cases. So this case is, you see the dotted line, that is the bony defect, but the dural defect is actually that little hole right there. So a very small dural defect. Versus this is a little different. This is more like that case I showed earlier where the bone and the dura are larger defects itself. So depending on the size of these, you have to decide on those three layers what you're gonna do. Small defects, a single layer will work. Free graft works just fine. If you've got, and sorry, let me say that was very small defects. Small defects, I like 2 layers. I typically use Duragen or again, some sort of synthetic material. And then I'll put either free graft or a small nasoseptal flap over that. And then medium to larger defects, that's where we think about 2 or 3 layers. So the one I showed you with the bone in the skull base, that I had 3 layers. I had Duragen, I had bone, and then I had a flap. But in general, my principle is if you can get 2 layers up there, you're usually in good shape. So what you want to do is, again, make sure that you have all the tools you need. The Bovie, I like glues. There are people out there who say you don't need glues. That's reasonable. Bipolars and then some sort of dural matrix. And then the first thing I'm going to do is strip all the mucosa around there. So get everything dry, pack it off, let it dry up, and then you're going to strip the mucosa around there, both because that's going to let everything adhere to it, as well as really let you know the size of the defect. And then assess the size of the defect and then decide on what graft you're going to use. Number of different grafts that you can use. Middle turbinates work great. Septal mucosa works great. I love floor grafts. They're super easy to harvest, especially with a little Bovie. So this was a patient where you can see that defect there. The floor, it gives you this nice size rectangular piece that's very regular versus like the turbinate sometimes can be a little irregular, and like the thickness of this is really nice. And then the other thing is there's really no donor site morbidity. So when you see this patient in the office 2 weeks later, that floor is already like beautifully granulating in, not crusty. It works so well. So if you're getting a free graft, I love floor grafts. They just work really well. Nasoseptal flaps, we're not going to go into too much. I don't want to belabor the point, but they work great. I mean, there's no problems with them. We use them for large defects. They, in general, heal pretty well. This is, let me see, I'll make sure I'm time. This is a post nasoseptal flap video, codec unavailable. So we're going to bag that. It looked great. You'll take my word on it. I hope the rest of these work. And then the other thing, this is different. This is an encephal seal. I never use fluorescein for our type of cases, but I just want to show you why I like the bipolar. So if you can take the bipolar and get the leaking to stop, you typically just need a single layer there. So that's what I do. So the first thing I do is I try to use that bipolar and see if I can fulgurate the area. And if the leaking stops, a nice single layer single layer closure will work. So flip side, if you can't get that dry field, so you're going to watch this. So we've got a leak, and I think this is this is the first picture I showed. So here I went to the bipolar, hoping I can just bipolar real quickly and kind of move on with it. But you'll look, it's still pouring through there. So that wasn't working. So that's when I think about other layers. So again, you see me, my go-to on these small ones is use some synthetic material there. And then once you use that synthetic material, in this scenario, I just used a free graft. And you're going to see that that free graft just sits really nicely there. And then I'll use some glues. And again, I'm going to get this patient admitted afterwards and make sure everything heals up well. And the post-op, this was a couple weeks post-op. It's not perfect yet, still inflamed there. And I tell my patients, if you have, so when we transfer someone in to repair that, they came for their sinus surgery and their sinusitis. So we do want to get that well and healed up, but I'll slow down my healing. So I hold off on rinses initially. I'll back off on some prednisone initially, just to get that leak healed first. And once a leak is healed, then I move into actually fixing the sinuses. So in conclusion, if you're concerned about a leak, step back, regain composure, and think about whether you had it. Identify whether you feel comfortable closing the defect. We talked about this. Equipment, facilities, knowledge, and you're mentally there. If you have those four, the skill set part's actually the easy part. But that said, I would have a low threshold for transferring intraop leaks if there's any concerns there at all. This is me and the family at the Michigan National Championship game. This is much happier thoughts and intraop CSF leaks. Thank you. 4 minutes.